Okay. My name's Natalie Perkins, and this is my week 5 case connection presentation. So for this week, I'm going to be discussing case 2 and case 3. So to begin with case 2, the normal conditions of very low density lipoproteins in the maturing phase is lipoproteins or VLDLs are produced in the liver through lipogenesis. And so the figure on the slide here really does a good job at illustrating this whole process. And we know that lipogenesis converts excess glucose into free fatty acids. These free fatty acids come into the hepatocytes and are esterified into triacylglycerols, which are then packaged with cholesterol, proteins, and phospholipids to form the very low density lipoprotein. The MTP facilitates this reaction with the ApoB100 protein, which allows these lipids to be loaded onto the VLDL. And then from there, the VLDL is transferred from the lumen of the endoplasmic reticulum into the lumen of the Golgi, where it goes through the maturing process and is then released into circulation by the liver. And then once it's released into circulation, as we can see in this visual here, the mature VLDL reacts with a high-density lipoprotein to acquire the ApoC2 and ApoE proteins. So these attach to the VLDL, and then the VLDL reacts with the enzyme lipoprotein lipase, which stimulates the hydrolysis of the triglycerol that was also on the VLDL. So the hydrolysis of this triacylglycerol breaks apart into glycerol and free fatty acids, which are then used by the extrahepatic tissues and metabolized. After that process, the VLDL remains attached to the ApoB100 protein, but it gives its ApoC2 protein back to HDL. And then ApoE protein remains on the VLDL as well, and the ApoE helps with the reuptake of VLDL back into the liver to be reused again. So in the case of this patient with suggested non-alcoholic fatty liver disease, we know that NAFLD is the accumulation of extra fat in the liver. So we can see that in the image on the slide here. The liver starts to just kind of fall apart when there's too much fat, and it can be under a lot of stress when there's excess fat in the diet and therefore in circulation, and then the liver just kind of goes on overdrive with trying to process all these extra fatty acids in the bloodstream. So the most common causes of non-alcoholic fatty liver disease can be obesity, dyslipidemia, and diabetes. So we know that our patient does have risk factors for these, as well as family history that puts him in a high risk category for this occurring to his liver. This chronic inflammation is marked by elevated levels of alanine aminotransferase and aspartate aminotransferase 2, which we saw in his lab results that those were both elevated. And then damage to the liver can also cause hepatic cirrhosis and hepatomegaly, which they saw in his ultrasound that he had. Basically, in NAFLD, there is a chronic fed state metabolism going on with lots of glucose in the bloodstream and therefore lots of fatty acid synthesis going on. And so this is manifested through excess triacylglycerols and excess triglyceride synthesis, and also more VLDL assembly. VLDL, along with LDL, is known as the bad cholesterol, which can cause plaque in the arteries and cause damage to the liver if too much is present. And like I said, the high levels of free fatty acids kind of create pools of triglycerols, and then some hormonal effects to NAFLD are elevated insulin or even insulin resistance, especially in diabetic patients, and low glycogen as well. And other symptoms are oxidative stress, apoptosis, and mitochondrial dysfunction. So basically, when the liver and the metabolic processes that the liver undergoes to metabolize free fatty acids, when this is all on overdrive, it can cause these functions to fail, which can cause further complications as we see here. So then for case 3, the hormonal status of this patient, I would just like to first start off by highlighting the lab results that stood out to me the most. And so first of all, the patient's blood pressure was 160/80, which at rest, that is a hypertensive blood pressure. And their A1C is 7.9, which puts them in the category for diabetes, having diabetes. Like I said, LDL is bad cholesterol, and we want that under 100 if possible. And this patient's LDL was 200. Their fasting blood glucose was also 221, which is very high as well. And total cholesterol and triglycerides were both elevated from normal levels too. So there's a lot of inflammation clearly going on in this patient's circulatory system. And as we can see here in this image, this kind of highlights the relationship between high blood pressure, high cholesterol, and high cortisol and adrenaline in the body. So basically, cortisol is our key stress hormone, and there is a pretty direct relationship between cortisol and cholesterol, and then also blood sugar too. So the more stress that you're under, it's been shown that that can increase your cholesterol and increase your blood sugar levels too. And adrenaline is another hormone that can also trigger our fight or flight response throughout our body. And so when we are in a constant fight or flight response, this boosts our low density lipoproteins and very low density lipoproteins, aka our bad cholesterol as well. So there definitely needs to be a lot of changes to improve this patient's cholesterol and just all around cardiovascular health. And then for cholesterol treatment, the chart on the graph here kind of goes along with the lab results on the last slide, but basically her total cholesterol was high, LDL was high, HDL was about 44, so it was a little low, not like terribly low, and triglycerides were high too. So we want high HDLs and low LDLs, which she did not have. So we're going to try to make changes with that, with medications such as statins, PCSK9 inhibitors, or bile acid sequestrants. So statins reduce cholesterol by blocking production in the liver and helping the liver remove cholesterol already in circulation. And they also inhibit HMG-CoA reductase activity, which therefore decreases the liver's cholesterol content and increases the production of LDL receptors so that we can uptake more of that bad cholesterol in the circulation. PCSK9 inhibitors help lower plasma cholesterol levels by increasing the number of LDL receptors available to clear cholesterol from the bloodstream, and they also block PCSK9 from breaking down LDL receptors. So this allows there to be more healthy available LDL receptors. So again, we can uptake that bad cholesterol more efficiently and have greater numbers of those LDL receptors. Bile acid sequestrants block the absorption of bile acid in the stomach into the bloodstream. And so the liver produces more bile to replace what's been lost, and this lack of absorption reduces LDL cholesterol in circulation too. So with statins and PCSK inhibitors, the most common symptoms are going to be muscle pain, muscle cramps, nausea, vomiting, headache, and stuff like that. And the bile acid sequestrants, their symptoms are mostly going to be gastrointestinal related, like stomach pain, nausea, constipation, indigestion, and stuff like that. So those are my case reports for this week. And here are my references as noted. And that is it.